Yes.
Yeah. Is that the
Okay. Yes.
one? Are you able to see it?
Yes, we can see that.
Thank you. Thank you for the introduction. I'm actually South African, but I managed to do my training in Namibia, after which I went back to work in South Africa. And of course, that meant that I managed to see the different ways of working in the different countries. And listening to the previous speaker as well, it would appear that primary health care seems to be different in each country. It was different in Namibia, it was different in South Africa, definitely different here, where there's a bit of fragmentation of services, as we've just mentioned. And that is how my study also came along. So for this presentation, we're going to look at the reasons that I actually decided to do the study. I'm going to share the research project that I did with my colleagues and the recommendations that came out of the research project. If I can just get this to move, right, it's not moving at all. Why is it not moving? Oh, there, it's moved, right. So the reason that we decided to do the research project, one, I was doing my master's level in public health, and we had to do a public health related topic and come up with a policy. And I decided to do my policy on smoking cessation. But the smoking cessation actually opened me up to a lot of opportunities at my workplace because I had to bring it back into practice. It made me realize that some of the patients that we see are actually smokers, and there was a great opportunity to actually talk to them about smoking when they presented for an illness or an injury. But going through everything and going through my literature review, it also, smoking was linked to the high rates of premature accidental deaths. So things like diabetes, heart disease, cancers, respiratory conditions, and also the ongoing and very high rate of long-term conditions, which we can't treat, but we have to manage with drugs. And that made me look at the wider aspect. So I didn't just, of course, I had to narrow it down. So I had to narrow it to smoking, overuse of alcohol, and obesity. Whereas there are things like sexual health as well, which also link to these long-term conditions and non-accidental premature deaths. So those were the rationales for the study. And in this country, I'm not too sure about your country, but in this country, the first point of contact for patients is a GP surgery. But in 2000, they started opening centers, which were then called minor injury units, minor illness units. They were at some point called walk-in treatment center, and currently they're being called urgent treatment centers and urgent care centers. So these kind of settings mean that instead of people going to an emergency department, they can just pop into a walk-in center or an urgent care center for a minor injury or minor illness. And in this country as well, the GP surgeries are not able to really deal with injuries. And as we know, a lot of our men who get injured a bit more, they need these kind of facilities to go to. And sometimes it's so minor that there's no need for them to go to emergency department. So these kind of settings were then opened. And in this town that I live in as well, we've got a very high rate of students. There's a very popular university here, Portsmouth University. So it's not only popular for the UK, but it's popular for international students as well. So it was a great opportunity to actually do a study to see how people would react to being asked about unhealthy behavior when they just presented for an injury or an illness. So as I've already mentioned, traditionally in this country, the role of health promotion falls within a GP surgery. It's a paid service. So a person will book an appointment because they've decided, okay, now I need to stop smoking. They will book an appointment with the practice nurse or the GP and say, this is why I've come to the surgery today. And they will then make arrangements for them to stop smoking or reduce their weight. But it's paid, it's booked, and it's pre-planned by the patient instead of proactive. But recently, with public health getting more and more popular, they've recently come up with a making every contact count, which means they are encouraging all practitioners. It doesn't matter where you are, whether it's a health background, whether you go to a library, whether it's a school, all those professional people to have these healthy conversations with whomever they get in touch with. So a person is going to the library for a book, they ask about their smoking, they ask about sexual behaviors, which I'm sure you can imagine is not very easy. I've just come in for a book and there you're asking me about my sexual behaviors. But the government is trying these initiatives because we're trying to reduce unhealthy behavior. We're trying to promote health, but it still doesn't seem to be very popular. The old practices, the traditional ways of working still seem to be the way forward. So making every contact count for one, it's definitely not being practiced where I work, which is an urgent treatment centers. So although these places are widely used, they were not utilizing them well. So when I then finished or completed my master's in public health, I decided instead of doing my studies in PhD HIV, which is what I'd wanted to do, I thought there was a greater need. There was a greater need of putting a focus on health promotion, on the opportunities in urgent treatment centers to actually talk to our patients about unhealthy behavior. But because because these centers are still new, as I said, they were only opened in 2000, there was no literature to show what is actually happening in terms of health promotion. So all you find is that people are going in for injuries, people are going in for illnesses, but there's nothing about health promotion. So I had to do a feasibility study to explore what is actually happening in my treatment center. Are there even patients who are coming in with unhealthy behavior? So it had to be in 4 parts. Those 4 parts, one being the profile study to see how many of our patients that come in actually have unhealthy behavior. I then went on to see if it was actually possible to implement very brief health promotion. So just ask, do you smoke? Do you want to give up smoking? When do you want to give up? Shall I make arrangements for you to go somewhere for where you're going to get help? Or do you feel that you're overweight? Would you like to do something about it? Do you know what your alcohol intake is per week? And do you think that it's perhaps more? Would you like any support? So those kind of questions, was it actually possible to ask these questions? Would the patient be receptive to these kind of questions at all? And after the randomized control trial, we then went on to do a patient questionnaire to see how they felt about being asked these type of questions when they had presented for an injury or an illness. I then went on to interview nurses to see how they felt about having to implement health promotion when they themselves had not been trained in health promotion techniques before. So we conducted the profile study, which was over 4 weeks. The patient group or the study focus was 16 years to 75 years of age, because we still have very active 75-year-olds who can still change their behavior. We explored if they would self-report. So a form was outlined for them, asking the questions. We wanted to see if they would actually self-report unhealthy behavior. We then went on to ask them about unhealthy behavior as well, in addition to the form. We found that of all of our patients presenting 0 to over 100, 70% of our patients were actually between the ages of 16 and 75. And in that 1 month that we collected the data, 76 patients actually had one or more unhealthy behavior. Smokers, there were 27%, overuse of alcohol, 4.2%, overweight, 40%, and obese clients were 22%. We then went on to do a randomized control trial, 2 significant entry points in the treatment center. One is for triage and one is for consultation with a practitioner. So of the patients that came, we took an equal number of patients, 204 in total. That was just based on a random number because there were no previous studies for me to be able to do the power. So I just had to go for 204 patients over a period of 3 months. We found that from these patients, 40% were smokers, 3% overused alcohol, 26% were overweight, 18% were obese. As you can see, it's actually a bit more compared to the self-reporting. Our intervention took 1 to 5 minutes. As I said, all it is asking, you're advising, you are then making arrangements for referral if they want a referral, and those who didn't want a referral, you're giving them a leaflet so that when they were ready for behavior change, they could refer themselves. So we did 22% of the referrals, but what we found was that there was actually no difference between the triage consultation and a standard consultation. The referrals were the same. We then went on to hand out a questionnaire to the patients to see what they felt about being asked these behavior questions when they just presented for a sore throat, for a rash, for a sprained ankle, and things like that. Again, the figures when they were doing the questionnaire, the figures of unhealthy behavior were a bit more than the figures when they came in. So we had 54% who smoked, 12% who overused alcohol, 55% were overweight, and 13% who were obese. 60% of our clients said they would use the health promotion service, and 82% said they would recommend the health promotion service to their family, their friends, and colleagues. And 70% thought that it was a good idea to integrate health promotion into a standard consultation, and 3% did not think that it was the right place. I then went on to interview 14 advanced nurse practitioners about their thoughts on having to implement health promotion, which they had not done in 15 years that the place has been opened. The nurse practitioners acknowledged that they had a responsibility in prolonging long-term conditions. They thought that there was a good opportunity for health promotion in the unit, and they thought that the research provided them with an opportunity to raise awareness, not only for themselves, but for their presenting clients. Barriers that they came up with were time. Nurse practitioners said that they didn't have time to do health promotion. They were fears. They didn't have the skills, but they wanted to do it. They wanted more training and they wanted more time. And it turned out when we asked them a bit more about time, it's because they thought that health promotion was almost like another consultation altogether. They said they thought it would take up to 20 minutes just to talk about unhealthy behavior. So when they actually engaged in the research project and when they were then trained in more skills to promote health, they found out that actually it just takes 1 minute, and they are now more and more confident. Although sometimes it's still not going very well, but at least it's there, it's a start. So conclusion from this research project, which just took 6 months only, over 70% of our presenting clients are actually between the ages of 16 and 75, which means there's a lot of opportunity there to actually change their unhealthy behavior. Over 70% of our patients accepted the screening and healthy conversation. There's a good opportunity, there's a great opportunity to integrate health promotion into a standard consultation. as I said, the nurse practitioners wanted more training, and they wanted more empowerment. So we're working with them to teach them about making every contact count, to help them to be more confident in engaging. Weight, obesity, that one seems to be a major problem with the nurse practitioners, because they feel that they don't want to offend the patients, but actually someone has to do this, and it's us. We also need to come up with policies that we're going to be able to use, so that we make sure that although we've put the practice in place, but there are also policies to help to support the nurse practitioners to actually implement health promotion, so that even those patients that perhaps might feel offended and might want to complain about being asked about their weight, but we've got policies in place and we've got management on our side to actually explain why we're doing what we're doing. The gap in knowledge, though, from this research project is that the speed with which these centers were opened was so quickly. The government only gave the tenders 6 months to come up with a proposal to open a treatment center, a walk-in center, an urgent care center. As such, there were no stipulations as to the education, the training, the skill, the experience that a nurse practitioner could come with. As such, there is positive evidence about the previously nurse-led units. Clearer evidence is needed so that we can adapt the nursing and paramedic education, so that we can ensure adequately prepared staff. So when these places were opened, it was only nurse practitioners, but over the past 3-4 years, they are now employing paramedic practitioners as well. So we've got more paramedics, we've got more GPs, we've got more nurses now as well. So for everyone to be equipped, for everyone to be skilled, to make sure that we're doing the consultations, but we're also engaging in health promotion, we need to rebrand and clarify the roles, the services, the practitioner skills, the education requirement. That way we are able to standardize everything, and we can make sure that even future nursing students, future nursing paramedics are able to engage in health promotion wherever they're going to work. So implications for research and education, which is now the way forward. So yes, it's okay saying we must engage our patients, but for us to be able to engage our patients, we have to engage our staff. So we want to develop a workforce that will meet the challenges of these rapidly developing centers, from qualified to non-qualified staff. There's no reason that a healthcare support worker can't engage a client while they're doing the dressing, while they're cleaning a wound, while they're taking temperature, ask about smoking, ask about weight as well. So it's for everyone, qualified and non-qualified. We want to invest in our current practicing staff. We want to make sure they're skilled, they're well prepared. They are not going to feel that they're going to offend patients when they ask about unhealthy behavior. We want to use these nurses and these paramedics and the non-qualified staff as well to make sure that they're not only practicing nursing care, but they're involved in research as well. The research that I did, it didn't cost me a lot at all, just some paperwork that I did. So there's nothing stopping our paramedics and our nurses to doing practical research that is going to then feed nationally, so that nationally they know what we're facing with at grassroots level. They know what is happening, so that they can then help to support us to get involved in research and make sure that we're also increasing the standards of nursing and paramedic practice, to make sure that our patients get better care, get holistic care as well. So in this country, there are also some pillars for advanced clinical practice. We want to make sure that we're fulfilling those pillars, which is education, which is advanced clinical practice, which is research as well. So by getting involved in research, by getting involved in education, in clinical practice, we are also fulfilling the 4 pillars of advanced nurse practitioners in this country. So that is what actually came from the research and the gap that was identified. So this does not now only work in this country, in the UK. This could be transferred all around the world. All around the world, we've got people who are living with unhealthy behavior. We've got people who unhealthy sexual practices. So we want to make sure that we are empowering our staff, each and every country, each and every contact. We want to empower our nurses, our GPs, our paramedics, by working with management, by working with the Department of Health, by working with clinical commissioning groups to make sure that there are sustainable policies, there are pragmatic policies that are going to help to train our nurses, our paramedics, our GPs. We need more research in this field. Emergency department, we want to see how they're able to make sure that they're implementing brief health promotion in their setting as well. So not only that, we're then going to be making sure that we're practicing evidence-based medicine. We need to modify current curriculums because we know in this country, the curriculum doesn't involve health promotion at all. So we want to work with universities to make sure they're adapting the curriculum, to make sure the paramedics, the GPs, the nurses are equipped. When they qualify, they're equipped and skilled to actually engage in health promotion. So we want to work with the universities. We want to work with multidisciplinary departments. We want to engage and work with researchers like you who are presenting at conferences so that you know what we're doing, we know what you're doing, we see how we can all work together. Conclusion, autonomous practitioners all around the world, they are rapidly growing. We need to equip our advanced nurse practitioners to make sure that they are practicing holistic care. We want a strong, robust education and training program that is going to help to improve staff retention, staff development, staff empowerment. We want a structured support system that is going to help our trainee general practitioners, nursing and paramedic staff. We want to empower all of our health practitioners so that this leads to higher standards of care, less mistakes, less complaints, accountability, confidence, and safety. Research is equally important because then it adds to what is known, it adds to our higher standards of care because we're able to say in our safe, practical environment, this is the research we've done and these are the findings, these are the gaps, this is what we're learning from the research that we've done, and this is how we can then improve our nursing practices, paramedic practices, and as such standards of nursing care. Those are the references that I've used for this presentation. Thank you for listening. Those are my contact details if anyone wants to get in touch. Thank you.